Topic is open for discussion.
One question for Dadich. I see surgeon missing from the list because most of the times dianycellular stent is not available in the hospital or in the town, and every center is not coped to do BRTO and TIPS procedure. So we recently had an experience, a massive variceal bleed not responding to EVL. We had to push the patient to surgery after placing a Sengstaken tube. Where do you see a role of surgeon in this?
Actually, when you look for the predictors of refractory bleed, it's the underlying liver function which predominates. Like if a person who's having a child C or a late child C or a high SVPG are more likely to have a refractory variceal bleed, because a bleed which is not controlled by the usual EVL and other things, they usually have a severe underlying liver disease. So subjecting that group of patient to a surgery is again difficult.
High risk, but we don't have any
Yes,
option. I told you our experience.
Yes.
We had to push him for surgery, and he survived devascularization.
Yeah, if they can undergo surgery, then probably it's a good option.
In this regards, you can take the mic. What we often do not discuss in these meetings is the role of coagulation, because we keep talking of balanced coagulation. Now your patient in this scenario has a platelet of 20,000, 30,000. INR is 3, 4. What do you do? He has rebled. Would you even take this into consideration? What's the hepatology status?
For repeat endotherapy or a radiologic procedure?
You have done a procedure, patient has...
You have to correct it, because that's where comes the importance of the underlying treatment of the underlying liver disease. If the underlying liver disease is advanced or it's a ACLF, then he's more likely to have these kind of complications which we are talking about.
So would you now, in today's era, correct the platelet, correct the
not by the
INR.
absolute number, but by the viscoelastic assay, and then you accordingly give the factors and then...
Okay, so please.
So patients with ACLF, when they present with bleed,
Yes.
they have very, very high risk of rebleeding.
Yes.
The portal pressure is so high.
Yes.
Would you change your practice in these patients going for early SEMS, or if they have a rebleed?
The first approach is always a stable, a person should be the endotherapy, doing EVL or glue or coil, whatever, depending upon the site of bleed. If they rebleed, then it again depends upon the underlying liver status, whether they are the candidate for liver transplantation or they're going into that futile category. Then once they are stable, then you can go for a shunting procedure. The TIPS can be done even a bridge-to transplantation also.
TIPS in our setup is very difficult generally, because if they decompose, the TIPS data mainly comes from the West,
Yes.
because if
For
patients
cirrhotics,
decompensate,
yeah.
you can get the next cadaver organ to the patient. Whereas in our scenario, that is not very easy to do that. So therefore, if you look at the whole literature, TIPS is very less performed in our country. That's one of the main reasons. So that's my question. So if the ACLF patients rebleed, I would say it's better to go for early metals, self-expanding metal stent, rather than rebanding and all those.
Yeah, that's why I thought endotherapy is the first preference of doing the procedure. Yes.
I agree with you, Dr. Dinesh. Actually, when you see these studies of preemptive TIPS, they are not actually reducing the rebleeding in that way. They are actually preventing further decompensation and hence improving the mortality. So one has to take that into mind, that once whether it is your short-term goal or you are looking at a long-term goal here. And preemptive TIPS, actually the survival benefit comes in selected group of patients, the CTP and active bleed and up to 13 and futility consent, because these are patients who will be helped by TIPS. Not only, obviously, they will prevent bleed, but mainly in preventing further decompensation and hence improving survival indirectly. So,
yeah. So if TIPS is otherwise also indicated, then you should prefer for TIPS then. Otherwise, stay for endotherapy. Do go for bridging and then repeat the endotherapy.
We can take one or two questions from the house, but in the meantime, a question to Dr. Dinesh. You mentioned that with SPP, you are okay to take up for transplant within 5 days of antibiotics. Is that, did I understand correct?
Yeah, that's right. So this is in an unstable patient. That's what I'm saying. If a patient has spontaneous bacterial peritonitis, particularly if they are ACLF, and if the liver function is not going to improve, and if they are stable, if they are not, even if they develop acute kidney injury, they are not candidates. They are candidates for liver transplantation. I mean to say they are not contraindication for transplantation. Particularly, what we have an advantage is the living donor transplantation, where you can actually plan the transplantation during the window time rather than waiting for the entire sepsis to completely recover. Yes.
And what's your take on gut colonization? Because many of the time you resolve the infection, not talking of the infection, and the bowel remains colonized with MDRs. So does it influence your take on subsequent?
Yeah, I mean, there are conflicting evidence on your gut bacteria, particularly MDR colonization in the gut. But the main problem is the liver. So once you change the liver-related sepsis and all those things it will come down. So that's a lot.
There's a question from the house.
Sir, good afternoon. My question is to Dr. Dinesh, sir. Sir, excellent talk. Just wanted to know, like if there's a patient and in a LDLT scenario, usually we do prior testing prior to the transplant. But unfortunately, 2-3 days prior to the transplant, the donor comes positive for COVID-19, and the recipient is not having any symptoms. Should we wait for the incubation? Because they are from the same household and there is always an exposure. So should we wait for the incubation period to go off for the transplant to go ahead, or how long should we wait?
Question is, what if the donor has become the COVID positive, okay, and the recipient isn't? This is not an uncommon scenario. It's even recently we had. So first thing is, obviously if the donor is COVID positive, they can't go for donation for at least for a week. So that gives an incubation period for the recipient to look at whether they turn COVID positive or not. So anyway, you're going to withhold the transplantation because the donor is not suitable actually.
But how long should we wait for the incubation period?
This is regarding your comment about coagulation correction and refractory variceal bleeding. I know we're on the other opposite ends of the house on this. There's a big RCT from ILBS which is looking at tranexamic acid for prophylaxis of preventing secondary variceal bleed, and they looked at the viscoelastic test and the fibrinolytic test, and there was absolutely nothing on either to show fibrinolysis. However, giving tranexamic acid for 5 days as an infusion at a dose which we know might cause microthrombosis elsewhere was found to have survival benefit. So what coagulation test can be used for actually correcting coagulation abnormalities when this very large RCT has demonstrated survival benefit for an antifibrinolytic agent where no fibrinolysis has been demonstrated by any of the yardsticks we currently have? That's the first. Second thing is, if we are going to be correcting coagulation, we need to be looking at the portal pressure reduction first. As you pointed out, survival benefit will come from portal pressure reduction, and by means of reduction of HVPG, further decompensation is prevented and survival is prevented. It has very little to do with bleed. So whether we correct the coagulation or we don't correct it, unless we achieve that portal pressure reduction, whether by vasoactive drugs or by TIPS, it's not going to help. And in high melt situations where TIPS is a contraindication, maybe Danicella may buy some time. If there's sepsis, then we correct coagulation, hyperfibrinolysis, and buy some time. But again, to correct coagulation, I'd like to point out to the house, it is generally dysfibrinogenemia, which is the problem. So giving fibrinogen concentrate and cryo might help more than giving FFP. That would be the very last thing to correct.
So that's yes, correcting coagulation. That's exactly what I meant. So it didn't necessarily means FFP. So correcting dysfibrinogemia, platelets to me is important because and as we say, the viscoelastic tests are not available everywhere. These are still in niche situations. So what we have in hand is platelet, INR, fibrinogen level, and that's what we have to make do. But the proof, and I keep arguing in this way, is that the patient is bleeding. I do not need any other proof. Obviously, I know the portal pressure is high. And then if I have deranged coagulation in a patient who is actively bleeding, I don't think I would want to ignore this fact Because
agree.
the proof is in the pudding. The patient is bleeding. And now I don't think viscoelastic tests tell
No,
me
I shall
that
be
his
the-
coagulation is stable.
Agreed with you, sir. Now I give you the same VET test result in a non-bleeding patient.
Fair
If that same VET test result is being attributed to being the cause of bleeding in a bleeding patient, why do we exclude the non-bleeding issue in a patient with the exactly same VET?
Because
So these are incomplete measures of
because now
coagulation.
you are comparing my clinical acumen or my clinical observation with a lab test. And if there is a discordance, that is my basic
Then
premise.
based on the clinical
between
situation.
my clinical suspicion and a lab test which doesn't agree with my clinical findings, then I'll believe my clinical findings. At the end of the day, the patient is bleeding in front of me. The test doesn't tell me that, look, he's stable.
And this is
I
how the
think-
tranexamic acid data has come from IPS.
I think in my unit, my practical approach is to a person who has refractory bleeding, look for two things. The MELD.CTP, if it is very high, then the person anyway is not going to survive for long. If that is normal, like his early child C or B, then the culprit is HPPG. You have to reduce the pressure some way or other.
But Bavino
No, these are simultaneous. Obviously, we are reducing the HUPG, we are giving the vasoactive drugs and all. Those we are not denying.
Yeah,
So
yeah.
they go on.
So, and
now
the
he's-
tips can be
and now-
performed despite
and
the
now-
abnormal
And now he's
coagulation.
refractory to your measures. That was the topic.
But-
These are not working.
Everything is intravascular, so tips is not a contraindication for doing
But
this.
Bavino consensus also says that FFP transfusions won't improve the survival in bleeding patients.
Fair enough. So FFP, yes, because the volume expand, but correcting dysfibrinogemia, giving respect to the absolute fibrinogen level, understanding that in alcoholics you will have dysfibrinogemia, infections cause, and there are endogenous anticoagulants. And at least so many of these factors, platelet functions go down. At least I think these should not be disregarded. And well,
We should aim at HPPG reduction.
so that's one thing. And so there is an implosion theory and there is an explosion theory. So everything is not portal hypertension. That's just my take. You have to have a primary clot formation at the site of the variceal rent, regardless of the portal pressure. Even if you cut, a clot has to form.
You will agree that it's been a great discussion, and both the speakers, the presentations were well-paced, organized, and the messages were clear. Now, we have with us Dr. Roy Mukda, who's one of the authors in the paper that Dr. Sunil quoted. So I'd like to close with some comments from him about the glue injection.
No, it has been well proved that glue and coil combination is a good option for the refractory bleed. We have used only it for refractory bleeds. And now the thrombin has also come into the place, so thrombin is also has been used. So probably we'll have more of that sort of studies. We need more studies on this thrombin also. But the other one is almost proved. That's good. Any comments? You can close. Thank you. Thank you for that.